All right. I am doing a part 3 for electroconvulsive therapy. And this time I wanted to talk about the parameters of the device itself. So there are several parameters that we need to be aware of as ECT practitioners, um, and that we can control on the device. So the main ones are, well, let me back up and just have you try to imagine what the machine is doing. So the machine is delivering these kind of square wave pulses, and they're bidirectional pulses. So the current is going in two different directions. So it's like an alternating current that is pulsatile. And so each pulse of the current has a width, basically the duration of the pulse, and we call that the pulse width. And that can vary anywhere from about 0.25 milliseconds to, say, 2.0 milliseconds. And anything below zero point 0.5 milliseconds is considered ultra brief pulse width, and zero point 0.5 and zero point 0.5 and above that we typically use is brief pulse width. Ultra brief, ultra brief pulse width, so less than 0.5 milliseconds, tends to be associated with more efficient seizure induction and fewer cognitive side effects, but possibly could be less effective. The next parameter that we can control is the frequency. So how dense, the frequency of these individual pulses. This is measured in hertz. So if you take a second and you just count how many pulses there are in a second, that's basically your hertz. So 20 hertz, 20 pulses in a second. So the hertz can range from, anywhere from about 20 to 100 and something hertz. The other parameter that we can control is just how long of a stimulus train we're delivering. So we're delivering these pulses, and we can do that for some period of time until we stop. Usually this is going to be a few seconds, so maybe 1 second to a maximum of 8 seconds. The other thing that we can control is the amplitude of each pulse. So basically how tall the pulses are, and this is measured in amps or amperes. All of these, if you basically multiply all of those parameters together and make sure that the units check out, then you get what's called the charge. The charge is measured in units of coulombs, generally for the ECT machine, millicoulombs. And it's essentially kind of a measurement of the total number of charged particles passing through, during a stimulus train. You can convert that if you have a resistance or impedance to joules. And the maximum device output for an ECT machine is 100 joules. And, just to put that in comparison, some of the electrical cardioverters are sometimes up to 360 joules. So ECT machines are generally putting out less energy than a cardioverter. The charge is basically the overall dose that you're delivering. And again, it's measured in millicoulombs. Oftentimes you'll see it measured in terms of percentage, like a dose of 20%. And that's just the percentage the percent of the maximum device output. So if your device can maximally output 500 millicoulombs, then if you set the machine to deliver 100 millicoulombs, then the device might give that an intensity percentage of 20%, because that's 1/5. Those are the main parameters. Now, how do we change those? Most devices will have some options, some tables that give you guidance on that. There's basically two main device manufacturers in the United States that make ECD machines. There's Thymatron, and there's the Sigma device. The Usually we're doing either bitemporal placement. So we put the stimulus electrodes on the temples, or we're doing right unilateral treatment. So we're putting one stimulus electrode on the right temple and one on the vertex, top of the head, basically, just trying to stimulate the right hemisphere. Bitemporal placement seems to be more effective, or at least can achieve clinical efficacy faster than the right unilateral treatment. A number of studies have shown that they can be equivalent if right unilateral is dosed higher, but that right unilateral might take a few extra treatments compared to bitemporal, but they can both achieve the ultimate end state, the same clinical outcome at the end. So if you're on the inpatient setting and you're doing ECT, oftentimes we'll elect to do bitemporal because we're trying to move things along faster. These are inpatient cases by definition. They tend to be higher acuity, et cetera. If someone is particularly concerned with the memory side effects, right unilateral, especially ultra brief right unilateral treatment, is associated with significantly fewer cognitive side effects. But again, it might take longer to get the same efficacy. There's another placement called bifrontal, where we put the two stimulus electrodes 5 centimeters above the outer canthus of each eye. So just right on that, right on the frontal part of the brain there. And again, we're trying to avoid the hippocampal structures, primarily those memory structures, temporal lobes. And that placement also seems to be associated with fewer cognitive side effects. But the studies on this are limited, so it's not clear how the efficacy compares to the other two. There's also another placement called LART, which is an acronym, LART, which stands for left anterior right temporal. So you put one stimulus electrode on the 5 centimeters above the outer canthus of the left eye, and the other stimulus electrode on the right temple area. And that is also designed to be a bilateral memory sparing placement. You're trying to avoid those hippocampal structures while still being a bilateral treatment hitting both hemispheres of the brain. That one has very few, I don't think there are any clinical trials of it. There's just kind of case series and case reports. So that one is very infrequently used just because there's not a lot of information on it. But those would be the 4 placement settings: bifrontal, bitemporal, right unilateral, that are used, and occasionally LART, LART in clinical practice. You could do left unilateral. The reason why we do right unilateral conventionally is because Broca's area and Wernicke's area, the language centers of the brain, are typically lateralized to the left in most people, even left-handed individuals. And so by stimulating just the right hemisphere, again, it just minimizes hitting important structures of the brain. But if somebody has some sort of right-sided lesion, or you somehow know that their language center is right lateralized, then you could certainly do it on the left. That's the only reason why we do it on the right. The reason why we put the tourniquet on the right foot is because if we're doing right unilateral, then we want to see that the seizure has generalized from the right side of the brain to the left side of the brain, and the left side of the brain controls the right side of the body. So if you tourniquet the right ankle and you're doing right unilateral and you see that the foot is moving, then you know that the seizure has generalized to the left. Now, I want to mention how we choose the doses. How do we choose these parameters? I mentioned earlier that the device manufacturers generally have some tables and things like that, but there are basically 3 main approaches to dosing for ECT. One would be just choosing a fixed high dose. So if you've got a case of severe catatonia, you might just pick a high setting on your device. You might even just choose the maximum setting and just treat them at the highest dose, because you're not really worried about cognitive side effects at that point. The person is mute and basically non-functional, so they've already got pretty profound cognitive or impairments. So yeah, you might just choose a very high dose and go from there. Other than those kinds of really severe cases where you're just trying to get someone better as soon as possible, the other 2 options would be basically like a formula-based dosing. So there are different formulas you might plug in the person's age and their gender, and there's some other demographics that you might plug in, and the formula spits out the predicted uh, dose for that person, the optimal dose. And again, that's going to somewhat depend on the device manufacturer. The more, I think, standard of care approach these days would be a dose titration or seizure thresholding. So with seizure thresholding, we're basically at that very first ECT, we're going to set the machine at its lowest dose basically and stimulate and then see if we get a seizure. And if we don't, we're going to increase the dose. And usually there are some tables that help you decide how far up to go. But you could just try doubling the dose, for example. See if you get a seizure at that next level. If you don't, you're going to try again and basically keep doing that up to say, 4 times until you get a seizure. So let's say they get a seizure at the dose level 2. That might correspond to, say, I don't know, 75 millicoulombs. And so that's your seizure threshold is 75 millicoulombs. For subsequent treatments, you're going to treat at a multiple of that seizure threshold. For a bilateral treatment, particularly bitemporal treatments, generally the effective dose is going to be 1.5 to 2.5 times the seizure threshold. So, well, just to make the math easier, if the seizure threshold is 100 millicoulombs, you're going to treat at 150 to 250 millicoulombs for subsequent treatments. Oftentimes, we might start at the low end of that, and if we're not seeing good seizures, then we're going to creep up, or if we're not getting the clinical outcome we want, we're going to creep up toward the 2.5 times. And sometimes, this is just a guideline. You might go up to 3 times or more potentially, but you're going to see more side effects as well as you go up. For right unilateral treatment, in order to achieve equivalent clinical outcomes as bitemporal, you need to treat at much higher doses. So usually you're going to be treating somewhere in the range of 6 to 10 times the seizure threshold. So if you're getting a seizure, if your seizure threshold is 100 millicoulombs, well, in this case, the seizure, that's actually a pretty high seizure threshold, and most devices aren't going to go above, say, 576 millicoulombs for the device that I use. So you're basically going to be maxing it out at that point. But that was just to make the math easier. So most people are going to have a seizure threshold much lower than that. And so you're going to be treating, again, 6 to 10 times, usually trying to stay on the lower side. Again, we're going to start with 6 and then we might creep up to, 7 or 8 times if we need to. We're going to be paying attention to seizure quality metrics. So there's the data and evidence on this is very limited. One thing we want to see is that someone's having at least an adequately long seizure. So depending on the source you're looking at, this could mean at least 15 to 20 seconds long. And usually we're judging this by the motor seizure length, not the EEG seizure length. So the motor seizure or the motor manifestations of the seizure generally last shorter. They're always going to be shorter than the EEG manifestations of the seizure. So you might get, a 10-second length of convulsions with the right ankle, but the EEG manifestations of the seizure might go on for 30 seconds. But if you're only getting 10 seconds of convulsions, then you still might do something. You might increase the dose or make some other changes, like seeing if you could lower the anesthesia to get a longer seizure. There is not a sort of linear relationship between the length of the seizure and the clinical outcome, however. So it's not that every additional second that you get a seizure going is going to be, an extra point lower on the PHQ-9 or something like that. It's really just, are you getting a robust enough seizure or not? If it's really short, it may not be effective, but, the difference between 30 seconds and 50 seconds is, as far as we know, not very clinically meaningful. The other thing, let's say you do have a 30-second seizure, which would be considered adequate. You're also going to be paying attention to a few qualitative markers of the seizure morphology. So you're looking at the tracing of the EEG, and you're going to be looking for the amplitude, how coherent each hemisphere is. Again, we're getting EEG tracings for typically both hemispheres of the brain. So we want to see that both hemispheres are lining up pretty well. We want to see good rhythmic, high amplitude activity. And then we're also looking for post-ictal suppression. So this is basically, if you look at a baseline recording of the EEG, so you let the EEG record what the baseline activity of the brain is while they're under anesthesia, but before we've induced a seizure, you're going to see some, random noise, some random activity, whatever the baseline activity of the brain is. It's not going to be very symmetrical. It's not going to be rhythmic typically. Um, and then if you compare that to the end of the seizure, usually if it's a good seizure, you'll get post-ictal suppression because all the neurons get kind of burned out, right? They just all go into the refractory period for some period of time. And so the brain activity is suppressed. And so it actually looks flatter than the baseline activity. So that's what you want to see. That seems to be correlated with good clinical outcomes, and that's called post-ictal suppression. So basically, just to review, we're looking for an adequately long seizure, at least 15 to 20 seconds by motor, by convulsions. And we're looking at the amplitude of the seizure on the EEG. We're looking at post-ictal suppression and just how rhythmic and coherent the two hemispheres are together. And if all those things are looking good, then we're going to keep the same dose that we've got. Over time, however, the seizure threshold tends to increase. So if you get a seizure threshold at 50 millicoulombs after 10 ECTs, the brain kind of adapts. And so the seizure threshold, if you were to recheck, might go up to 75 millicoulombs or something like that. So you might end up seeing some degradation of that seizure quality, and then you might need to start creeping up on the dose later in the course of the series. And typically we're doing 3 treatments a week for 2 to 4 weeks in an acute series. So a total of 6 to 12 treatments to get someone into at least response or remission. And then you might elect to do a tapering off, where instead of 3 times a week, you might drop to 2 times a week and then 1 time a week, or go straight to 1 time a week. And then transition into a maintenance phase where you're doing kind of like booster ECT treatments every so often. That could be every couple of weeks, once a month. And that is individualized based on how long the patient can go before starting to see recurrence of symptoms. If it's something like catatonia, they may not need maintenance. You get them out of the catatonia, you treat the underlying cause, and then they don't need maintenance ECT. If it's something like depression, which is highly, unipolar bipolar depression, which is highly recurrent, then oftentimes these folks do need maintenance treatments to stay well. All right, well, I think that's pretty much everything I wanted to cover for ECT for now. Obviously, I can't go over every single aspect of ECT. I don't want to make this podcast just about ECT. So if anybody has any specific questions, they can email me at brandon@outlace.com. That's BRANDON at OUTLACE.com. And, if I get the same kind of questions, I'll be happy to do another recording on something more specific.